So next we move on to the next topic, which is tests of accommodation and convergence. So that is the basic thing of binocular vision anomalies. And we have Dr. Remya Edachery. She is a pediatric ophthalmologist consultant from Pioneer Cooperative Hospital. So over to you, Dr. Remya.
Good morning. So, whenever we say non-strabismic binocular vision anomalies, the most important thing is to do a refraction. Do a monocular refraction, binocular balancing. Because if you don't do your binocular balancing, that can give rise to accommodative issues and convergence issues. Okay. So that is the most very important thing before going into an orthoptic evaluation. Just think of a child who is not wearing glasses, a myopic child. What happens? The accommodation is not coming. So convergence insufficiency happens. It leads to intermittent divergent squint. Another child, moderate hyperopic child is accommodating more. So that leads to convergent squint. So all these anomalies can happen if the child is not corrected properly. So before doing anything, you also have to do a stereopsis, Worth-Ford test and cover test. So I will be covering tests of accommodation and tests of convergence and the normative data. So as I told, accommodation and convergence, they work together. If you have accommodation issues, you can have convergence issues also, and vice versa. As we know the term AC by A ratio, so every diopter of accommodation, there is some amount of convergence. Coming to the test of accommodation, this includes accommodation amplitude, near point of accommodation, that gives you the strength of accommodation. Then the negative relative accommodance, that is the relaxing ability of your eyes to accommodate for accommodation, and positive relative accommodance, that is the stimulating ability to accommodate. Then comes the accommodation facility and MEM retinoscopy. These are the 6 tests you should know in accommodation. Okay. Accommodation facility and MEM retinoscopy test the flexibility of accommodation, how much the patient is able to relax and stimulate accommodation. So first comes to the coming to the near point of accommodation. This is done with an RIF ruler. So you have to explain the patient to look at the N8 target of your RIF ruler and keep moving the target towards the nose. When the patient sees the first sustained blur, that is very important, sustained blur. You have to ask the patient to close the eyes and again see. And first sustained blur, that is measured in centimeters. That is the accommodative near point of accommodation. This accommodative amplitude of accommodation is nothing but 100 divided by that much centimeter. So you have 10 centimeters of NPA, it will be 100 divided by 10, that is 10 diopters. Amplitude of accommodation is dependent of many factors, the most important of which is the age. We know when the age increases, the amplitude of accommodation decreases. So you have an expected amplitude of accommodation for each age. So this is calculated by different formulas. The most important one are the Hofstadter's formula, that is 15 minus 0.25 into age. And we have an Indian data from Dr. Jamila Rizwana, that is 18.5 minus 0.3 into age. That you should know. So if the child is having 10 years, you will get 18.5 minus 0.3 into 10. So 18.5 minus 3. Like that you have to calculate, and you have to see your amplitude of accommodation, what you have calculated, and see if there is a plus or minus 2 standard deviation difference. According to that, you will calculate whether there is a decrease in the amplitude of accommodation. Now coming to the negative relative accommodation. So this is your relaxing ability of accommodation. So negative means relaxing ability, you have to put plus lenses. What you do is, you will put plus 0.25 diopter lenses in both eyes in increasing increments. So when the patient sees the first sustained blur, then that will be recorded as the negative relative accommodance. So if you are getting plus 2.5, you will record it as plus 2.5 diopter. Similarly, you have positive relative accommodance. So this is your stimulating ability of your accommodation. So instead of plus lenses, you will be putting minus lenses in increasing increments. So minus 0.25, minus 0.5 like that. And whenever the patient gets the first sustained blur, you will take it as the positive relative accommodance, like -2 or -2.5 diopters. Coming to accommodation facility. Here you need an accommodation flipper. I am holding that in my hand, right hand, and you need a rock card, and what you do is you ask this is NH letters. So it comes in this accommodation flippers comes in two measurements, that is plus or minus 1.5 or plus or minus 2 diopter. You have to flip the this flipper and ask the patient to read clearly. So whenever the patient sees clearly, you flip again and you take the number of flips in 1 minute. So if you are getting 16, the accommodation facility will be 8 cycles per minute. 2 flips is 1 cycle. Okay. Then comes the MEM retinoscopy. Here the patient has to wear the refractive correction in place. Ask the patient to look at the distant target, then look at your MEM retinoscope. Read the MEM retinoscope and you measure the value. So normally there is a lag of plus 0.25 to plus 0.75. If the lag is more than 0.75, if the value is more than 0.75, you call it as a lag, and if it is less than 0.25, you call it as a lead. So it should be done in a well-lit room. So these are the tests of accommodation. 6 tests I have explained. Now comes to the coming to the test of convergence. Here you have near point of convergence, negative fusional vergence, positive fusional vergence, and vergence facility. So like NPA, NPC is also done with an RAF ruler, or you can also use a pen light and a green filter where you see 2 images. So like this you have to keep on moving the image, that line, towards the patient's nose, and the patient will see the first break. Okay, that is recorded as the break point, and again you come back when the patient sees a single image, that is the recovery point. So you have the break point and the recovery point. Next is the negative fusional vergence. But normal human eye has a tendency to converge. So always positive fusional vergence is done for near first, followed by distance, whereas negative fusional vergence is distance first, then for the near. Okay, so negative fusional vergence, you have to keep the prism base in. So it is done with the prism bars. I have shown the prism bars on there. I hope all of you have seen the prism bars. So you have to keep the prisms with a base in front of one eye, and patient has to read the distance target. Okay, then you will record the first blur. Then when the patient sees the break, 2 images, then again come back and record the recovery. So this is done for distance first, then for near. Similarly, you have positive fusional vergence. So here you will do it for near first, then for distance. So here you will place the base out prism, that is apex is towards the nose. So here you will again record the blur, break, and recovery. Coming to the vergence facility, like accommodation facility, you have the vergence flippers. Okay, so vergence flipper comes in 2 values, that is 12 base out and 3 base in, and 16 base out and 4 base in. So you give the patient the target and flip like that only, same. You have to flip the flipper. When the patient sees single, again flip. So you will record the number of flips divided by 2 will be the cycles per minute. So then another term you should know is the AC by A ratio. So this is usually calculated by the heterophoria method or the gradient method. In heterophoria method, you will measure the near deviation and distance deviation, and the distance you have used. So the difference between the near deviation and distance deviation divided by the distance used plus IPD will be your AC by A ratio. Whereas in the gradient method, you will use lenses. So it can be done either for distance also and near also. If you are doing for distance, you take the measurement without lenses, then with a -3 diopter lenses divided by that much diopter you have used. If you are using it for near, you have to do without lenses, then with a +3 diopter lenses. See the difference and divided by the number of amount of lens you have used. These are the normative data. So stereo acuity is usually 20 arcs of second. Then normally you have a fusion for distance and near. Distance exophoria is very less, and near exophoria you can have up to 3 to 4 prism diopters. AC by a ratio is normally 4:1, and with a standard deviation of plus or minus 2. And the near point of convergence, it's about 5 to 7, and with a pen light if you are doing, it comes to about 7 to 10. And distance near fusional vergence is 7/4, and for PFV near is 19/14, and the vergence facility is 15 cpm. This you have to just stick it onto your OPD wall. Okay, you cannot just mug up. So these are the tests these are the other values. Thank you.